One of the questions we received is what new information was shared with the trials looking at CDK4/6 inhibitors in metastatic breast cancer? Has a clear winner between the three been identified? And perhaps as you answer this, doctor, just remind the audience, the CDK4/6, when they're given in what setting?
Yeah, no, thank you. This is probably the most important breast cancer messaging that came out of ESMO. So remember, when we think about breast cancer, it's not all one disease. It's really three main categories of disease defined by the receptors on the outside of the breast cancer cell. We have hormone receptor positive breast cancer, that's HER2 negative, that's the largest category. We have HER2 positive breast cancer that can be positive for hormone receptor or negative for hormone receptor. That's the second most common category. And then the third category is when the three receptors that we look at, estrogen, progesterone, and HER2, are all negative. And we call that triple negative breast cancer. So when we organize our thoughts about like what are we studying and what's the tumor biology and what are our strategies, we generally try to think in the paradigms for each of those three subsets. Although, as we'll get to a little later, we're starting to see some blending of the subsets, which is creating a lot of exciting change in the breast cancer world. So as I mentioned, the largest group is hormone receptor positive, HER2 negative. And about 8 years ago, we began using a category of drugs called CDK4/6 inhibitor. CDK means cyclin-dependent kinase. And these are pill medicines that are taken in combination with a hormone partner, a hormone medicine partner, designed to slow and stop the growth and cycling of the cancer cell and eventually push the cell into cell death, which is what we want, because we want to try to kill the cancer. These are not chemotherapy medicines. These are what we call targeted therapy medicines. And at this point in time, we have 3 approved agents for metastatic disease. We have palbociclib, also known as Ibrance. We have ribociclib, and we also have abemaciclib. And so all 3 agents are FDA approved. They are all approved to be used in combination with a hormone partner, which could be an aromatase inhibitor or it could be fulvestrant. And over the past several years, there's been, I think, a really broad acceptance of how important these drugs are for breast cancer patients. And so for the majority of people who are diagnosed with metastatic hormone receptor positive breast cancer, a regimen with one of these agents and an endocrine partner is the preferred treatment. There are about 7 or 8 very large randomized trials that have looked at these 3 drugs. And very interestingly, across the board, the trials have all shown the same initial result. And what we're looking at is something called progression-free survival, which means in patients who start the hormone medicine and the CDK4/6 inhibitor, how long can it keep their cancer shrunk or stable until they need to make a change to something else? So all the studies are designed to look at that as the primary outcome. And across the board, when people receive a CDK4/6 inhibitor with an endocrine partner, it basically doubles the period of time that they're able to stay on their therapy. And this was very consistent on all 3 drugs. The drugs, so we've all thought of them as drugs that function fairly similarly, although there are some subtle differences in side effects and monitoring and things like that. What's been new this year in 2022 is now we are seeing longer term follow-up from those randomized trials. Importantly, looking at the trials that explored these drugs as the very first step, so the very first treatment that patients receive, we call it first line. And we saw data presented at ASCO, so our June meeting, just a few months ago, looking at the primary outcome of overall survival. So basically, do you live longer when you get this drug compared to not getting this drug? Now, the trials, again, were designed to look at that first endpoint, progression-free survival, but they follow patients longer to try to look at that second endpoint, overall survival. And what was shown at ASCO a few months ago was that data from 2 of the drugs, palbociclib and ribociclib, were both presented. In the trial where patients received ribociclib, the patients who received the ribociclib lived longer than patients who did not. That's the overall survival benefit. So we would call that a positive result. In the palbociclib trial, the data was a little difficult to interpret because the trial was not designed to collect all of that survival data. But from what was collected, it did not appear that the patients who received the palbociclib were living longer compared to those who did not. And this is despite the fact that it still gave that doubling of progression-free survival. So those are two of the CDK4/6 inhibitors. I mentioned there are three, and what we were waiting for was data from the third drug, abemaciclib. So that was presented at ESMO from a trial called Monarch 3. All the trials have these cute names. And in that trial, this was not the final result of the overall survival, but it was an interim result, suggested that patients who received the abemaciclib were living longer than those who did not. Technically, the number of months they captured was 12 months, but that is an average for the whole population. That's not for an individual person. Because of the way this trial is designed, that was not called a significant result yet. It has not matured enough for it to be called significant, but it certainly was trending in that way. The results favoring the abemaciclib were particularly notable in people who had cancer that had traveled into an organ like liver or lung, what we call visceral disease. So although technically not significant, I think people felt very favorable with these results and showed very nice activity from the abemaciclib. I think the most important message we have now is, and we've always had choice, but now we really have choice. And when we have these three drugs, we can say which is the right drug to pick for my patient. Up until about June, many people were given palbociclib as the partner agent. That's what has been most popular around the world, mostly because it is a very well-tolerated drug, and it's a drug where we are very good at managing any side effects. Since the data presentation at ASCO, there's been a little shift, and now more patients are being given ribociclib. Although for people who are on palbociclib and doing well, we want them to continue on that drug. And now we have the data supporting abemaciclib as well. Abemaciclib has slightly different toxicity. For example, it's a little more likely to cause diarrhea than the ribociclib. The ribociclib is a little more likely to cause some liver irritation. And so if there's a specific situation going on with a patient where we need to be mindful of these side effects, that can influence how we select. So there's still a lot more data to be coming out about CDK4/6 inhibitors, but these drugs are very important drugs in our breast cancer management. And this data is helping us refine our drug selection so we can try to get the best possible outcomes for our patients.
That's great, thank you.